This is Becky Spicer at the Children's Safety Network. I'm the director of the Children's Safety Network Data Center, and today we'll be doing our postponed Safe Infant Sleep webinar. So thanks everyone for coming today. Just briefly before we get started, let's have Rebecca do some housekeeping. Rebecca, can you give them some technical notes?
All right. Thanks, Becky. So there are two options to hear today's audio. You can either listen through your computer speakers or call into our phone line at 866-835-7973. If you're participating via phone, please mute your computer speakers to eliminate echoes. Phone lines will be muted during the presentation to eliminate any background noise. If you have any questions or technical issues at any time, you can type them into that Q&A box on the bottom left. After the presentation, we will pause for the presenters to answer your questions. We also have a couple of links available today on the left. To visit a web page, you can either you can click on its name and then select the Browse To button. A PDF of the slides is also available in this link pod. This webinar will be recorded and archived and sent out to all registrants after the session. And that's all I have. Back to you, Becky.
Great. Thanks a lot, Rebecca. Well, let's just set the tone real quick. Today we'll be talking about safe sleep, and as we all know that in 1992, the American Academy of Pediatrics recommended that infants be placed for sleep in a non-prone position. And, you know, since then we've seen a decline in the number of sudden infant death syndrome cases, but it remains the third leading cause of death ahead of maternal complications and unintentional injuries. To put it in context of the overall injury problem, sudden unexpected infant death, or SUID, is by far the leading cause of fatal injury among infants. In other age groups, the leading causes are motor vehicle traffic and intentional injuries. The four categories that make up the broader sudden unexpected infant death classification, the largest is sudden infant death syndrome. It's declined substantially since the AAP recommendations for safe sleep in 1992. And the steady decline is shown here in red in the graph. But in the last decade, the declines have plateaued. And in a renewed effort to get the message across, states are designing and implementing and evaluating new programs and policies. So on the webinar, we'll hear first from Suzanne Bronheim at the Georgetown University National Center for Cultural Competence about the National Action Plan to Increase Safe Infant Sleep. Then we'll hear from Rachel Heitman about Tennessee's efforts in implementing their statewide Safe Sleep campaign. So let me introduce our first speaker, Suzanne Bronheim. She's a Senior Policy Associate at Georgetown University National Center for Cultural Competence. She was Director of the Sudden Unexpected Infant and Child Death and Pregnancy Loss Project within the NCCC for 15 years and currently serves on the National Action Partnership to Promote Safe Sleep, NAPS, Steering Committee. For over 10 years, she coordinated Communities Can, a national network of communities dedicated to using collaborative systems integration strategies to support and serve all children and families, including those with or at risk for special health care needs. She served as PI for the MCHB-funded research project to address racial and ethnic disparities in access to information by families of children with special health care needs, and is part of research teams conducting validation studies on measures of provider cultural and linguistic competence and family-centered care. She has provided training and technical assistance related to cultural and linguistic competence to state Title V and other public health programs, to health and mental health care systems, to nonprofit organizations, healthcare providers, and family advocacy and support organizations. She's also developed resources on the role of cultural and linguistic competence in infant mortality disparities, approaches to implementing cultural and linguistic competence in health promotion, and providing culturally and linguistically competent services and supports to families. So Suzanne, thank you so much for joining us. Take it away.
Thank you. So I am glad that we're all together. And let me just get to my slides. Okay. So I'm going to talk a little bit about this new project that the Maternal and Child Health Bureau has funded over this past year and a half, the National Action Partnership to Promote Safe Sleep. And we know NAPS is kind of cute, but when the FOA came out, it was called the Systems Integration Safe Sleep Initiative, which is SISI. So we had to change the name. Part of it was the Bureau really wanted to step back and think about what would be a new approach to what we're trying to accomplish related to the sudden unexpected infant deaths. So we've had the AAP guidelines, we've had Back to Sleep, we've had Safe to Sleep. There's been so much activity, state and local levels, but there really had never been sort of a comprehensive national strategy beyond the campaigns that we've had. And the problem is that we're, as you saw, we've sort of plateaued. And what we're hearing from qualitative research and from the field in general, that while caregivers may know what we're telling them about safe sleep messages, they're not necessarily changing their behaviors. They want to understand the reasons for it. And we still have these persistent racial and ethnic, particularly racial disparities. So the Bureau said, let's take a step back, and they really wanted to think about this from a different perspective and really think about it from a behavior change perspective. And in order to do that, they thought we needed to think about several things. The first was that they really wanted us to try and figure out how could we integrate approaches to breastfeeding and safe sleep, because there's been a lot of struggle around those issues. Breastfeeding is protective in terms of SIDS, but most importantly for families, really, when you bring your baby home, what are the two things you're most worried about? How am I going to feed them? And what's the sleep thing? How do I get them to sleep? How can I ever sleep again? And so we felt we needed to bring these two things together, and that's what they wanted us to work on. The other was that actually in the FOA they said, we want you to use Asian's theory of behavior change and a few other things to really have a theory-grounded approach to behavior change. So it's not just that we want to get information out to people. It's not just that we want them to know the message, because we've spent, I don't know how many years talking about what is the right message, but really, how do we help people change behaviors? So the first piece of that was Asian's theory of planned behavior. And what that basically says, if somebody's going to change a behavior, first they actually have to know about it, so all of our awareness work, and think it's a good idea. Secondly, though, important people in their lives have to say to them, yeah, this is something you should be doing. He calls it subjective norms. And then the last piece is that they have to have the skills and resources to implement it. And truthfully, safe sleep and breastfeeding are not all that easy to implement. I mean, if you really want to get some sleep, trying to, stick to, quote, the rules can sometimes be pretty difficult. And what we hear from families is, sure, if the baby will sleep by himself on his back in a crib with nothing in it, I'm in for it. But if not, I need to have some way to understand how to make this work for me. So if we think about this, I mean, we see it in lots of public health examples. I've put several here, but smoking, for example. First we did a lot of the awareness building, I have to think it's a good idea. Surgeon General's report, the warnings, PSAs, people finally kind of came around and said, yeah, smoking's not such a good thing, unlike the days when we had doctors advertising smoking as a health benefit. But really, stopping smoking is not easy, just like safe sleep and breastfeeding. So that outlawing it in public places and workplaces, that was that second phase, that kind of pressure. But we still know people who struggle to make the behavior change. And that's where we have to do the piece where we give them some way to have self-efficacy, to have the resources to do that. So now we're trying to do quit lines, smoking cessation, and other things. The other thing is we sometimes do things and then there's unintended consequences from them. So like when we had Back to Sleep, all of a sudden people were saying, oh, the tummy's never good, and we had to go back and say, well, no, they should play on their tummies. Or with smoking, we're hearing moms are buying that they should not smoke around their babies. So we're hearing things from public housing where moms are leaving their babies alone in the apartment because they're not supposed to smoke in their apartment. because that's the second phase to support it. So they go outside to smoke, and now we've got babies alone in the house. So we're always having to reassess this and think about those three factors. The other piece is we started to think about how do we get people to accept something new, do something new. And in this we turn to Rogers' diffusion of innovation. And what he says is that people will adopt something new if it's communicated through channels of their own social system. And this is a two-way communication. So he said, yes, it's great when we have our awareness campaigns and we give people information. That's one-way communication. So people have to know about safe sleep. But to get them to adopt it, we really need two-way communication. And it has to be a back and forth before they're going to work through and figure out if that's something they want to do and can do. So we've been calling this concept moving from campaigns to conversations. We feel like this is the next new frontier in how we're going to work to get behavior change related to safe sleep and now breastfeeding. And this is a part of what we'll be working on. And hopefully maybe you have some ideas to share with us. But it's really the idea that we can't just tell people what to do, but we have to engage them in a back and forth and help them think through what are their plans for really implementing it and what would they need to do that. Finally, the Bureau said we have to make safe sleep everybody's business. And so we have to think about the socio-ecological model. So it's not just about addressing the actual infant caregivers, but the people who daily influence them, and this is family, friends, but it may be child care providers, it may be somebody else in the neighborhood, it may be healthcare providers. And then we have to think about who influences the influencers. So organizations that can either require them to do that, so we're seeing a lot of things in hospitals now where policy is being made about how babies are put to sleep and how parents are educated, or organizations that are bigger than that that can impact a whole area of practice or influence. Then we have the people who've been working on safe sleep, and they are the ones who have to keep pushing the message down. Public policies, federal, state, governmental kind of policies. In our case, there's no family leave. Mothers have to go back to work early. All these things make it harder to both breastfeed and to deal with the sleep issues of a new baby. And then broader cultural attitudes and political will and that sort of thing, including sort of a societal belief that a good baby is a baby who sleeps a long time and who sleeps through the night early. And parents are made to feel like they're not a good parent if that baby's not sleeping through the night early. And that leads them to do all sorts of things that we would hope they wouldn't. So, naps. What are we supposed to do about all this? It's a little scary, 3 years of funding, supposed to fix the world. But we have to create a national action plan, which we have done and we'll talk about in a minute. We have to engage a strategic national coalition to help us figure out what to do in that plan. We're going to have action teams, integrating safe sleep and breastfeeding, moving from campaigns from conversations. And then on our website, and I hope you will go there, there's an interactive version of this plan where you can put in what you're doing to address different actions related to the plan. So we started with ourselves, and this is Georgetown, and then we have external leadership from First Candle, Tomorrow's Child. You can see Rachel Moon is on there, and our federal partners. And then we started with the expert leadership group. I call this the usual suspects, those of us who've been working on this issue for a long time at a national level, to start to give a shape to the plan. What are the things we really think we need to address, things we wish could happen over time? But then we realized if we're going to really think about that socio-ecological model and really make it everyone's business, we had to make a lot of new friends. So the next phase was to reach out to a set of coalition members from organizations that we thought could influence the influencers or could make a difference in systems. And we brought them together at an action forum help us decide, so what kind of actions would be involved. So you get an idea of the extent of this in the slides: early education, healthcare provider organizations, racial and culturally specific organizations. We have breastfeeding advocacy organizations, health and human systems organizations that are bigger systems, media and businesses. And what's fascinating is these people are all in. They are so excited about doing this work and so much see what role they could play in promoting safe sleep and breastfeeding. So they're very engaged with us. And they helped us create this national plan. So the purpose is that it's not just for NAPS, it's for the nation. It's all of us together. It gives us some kind of way to organize what we're doing and how to move forward. You'll see in a minute that the goals are related to the 3 phases of Asians theory. And it's a way to sort of, that states and other people can justify what they're doing in terms of resource use because it's supporting a national plan that MCHB has put forward. So we actually, as all plans do, we have a vision that babies will sleep safely every time, and that we're going to work with a great array of partners to get systems to support and work together. We have overarching principles. We want to make sure we're addressing those populations where they have the more burden of SUA deaths, and doing that with cultural and linguistic competence. We then engage actually infant caregivers in their communities in what we're doing, and activate systems and services that touch families, which is all of those partners and then their community representatives. Promotion of safe sleep and breastfeeding together, and recognizing that families are the ultimate decision makers. We can't tell them what to do. We need to engage them in making decisions to change behaviors. So the National Action Plan has 3 goals, and it's all here, but we're not going through it, believe me. The first one is that they'll understand the advantages of safe sleep and breastfeeding and feel positively about those, which is the first part of the Asian theory. And the actions under this are really about making sure we get accurate information out to them and using our national partners to push that out through their networks so that everybody is talking about the same approaches to safe sleep and breastfeeding. And promoting this idea of having conversations rather than telling people what to do and how to do that. The second goal is really around those influencers, so trying to help them understand and accept and promote safe sleep and breastfeeding, and using the networks that we have engaged and getting them to provide training for their members and giving them tools to do that. And then the third goal, let me get to that, is really making sure that they have access to knowledge and resources and ways to really make breastfeeding and safe sleep work. And this is everything from making sure they have a crib and know how they can get a breast pump to helping them understand what normal sleep practices are for babies so they're not trying to force them to sleep long and all night. And then really looking at some of those social determinants of health in terms of engaging those organizations to support families in the broader sense, because when families under chronic stress and chaos and struggling in their community, it's pretty hard to implement these pieces. So then the next little piece that we're doing are these action teams. We have 4 of them. One group is working, we actually have a great engagement from the child care community, and they're very eager and interested at the national level to push down through their networks the idea of training around safe sleep and supporting breastfeeding in child care, and perhaps even developing some broader internal pressure for that, because they really understand now that they can play an important role in that. And we're hoping that if we can get that going at the national level, that will help you greatly at the state and local level. We have the organizations themselves who finally said, gee, we could use our networks to get this information out. We just need help in knowing what and how. So there's a group working on that. Another group that's looking at what they are doing, and is what they're doing really consistent with the evidence and with approaches to families and integration. And the last one is public media, a group that's really trying to tackle, we see all the images of the wrong thing, all these, the modeling of inappropriate behaviors, and to figure out how can we deal with both social and public media in mass media. And we actually have a mommy blogger who's helping us work on the social media. The other piece is this idea of a conversations approach, and what on earth is that? And we're struggling to figure that out so we can sort of pull some things together, some toolkits, some kind of training. If you have ideas or you've done something like that, I'd love to hear about it. But that's coming this year. And without, as I mentioned, through all of this, cultural competence and equity becomes a really important piece. So the plan, this national plan, can help you organize your ways of how you want to approach behavior change, can help you justify funding, it can help you find out what other people are doing and see what others are doing to support the plan. So we can help you. If there's a sector that you're having trouble with and we have that national organization involved, let us know. We can help you make that connection. Those action teams, as I mentioned, are going to be doing things we hope that will support you. And then what we hope you will do is you'll go to the website and document what you're doing, share your progress, and then sign up as a friend of NAPS. We have a newsletter that goes out, and we let you know what the action teams are doing and what other people are doing in relation to the national plan. And this is sort of what our website looks like. And this is what the interactive plan is. So you can see, you'll see a goal, you'll see a strategy, you'll see some actions, and if you click on the action, there's a little box that'll pop up, and you can write in, and just really, it only has to be a few sentences on who you are. Oh, we're doing something related to this action. So we hope that that gives you like a sense of what we're about. Call us, email us, go to the website, and we really hope that what the Bureau has done with helping all of us really focus on behavior change and with a theoretical model, this is going to help move the field forward. So thank you.
Thank you, Suzanne. That was very helpful. Did you have anything else to add?
No, I was just going to say I think Rachel's on next, right?
Yes, I think Rachel's on next, and I was going to introduce Rachel. Let's leave the questions for later, just to make sure everyone has enough time. Let me introduce Rachel. Rachel Heitman has worked for the Tennessee Department of Health for over 10 years, first as a health educator, and for the past 5 years as the Director of Injury Prevention and Detection. So in this role, Rachel is responsible for overseeing multiple programs, including injury prevention, rape and violence prevention, child fatality review, and fetal and infant mortality review. Rachel is also responsible for implementing the statewide Safe Sleep campaign in Tennessee. Rachel has a master's degree in mental health counseling and a bachelor's degree in psychology from the University of Wisconsin. Thank you, Rachel. Go ahead.
Thank you, and good afternoon, everyone. So today I'm going to talk about sleep-related infant deaths in Tennessee and our statewide Safe Sleep campaign, and then tell you about some specific projects that we have implemented here, including our hospital policy project, WIC educational module, Safe Sleep Floor Talker project, and the DOSE program, and then show you how some of those initiatives that we've implemented have influenced our data trends. This just shows some of the sleep-related death data in Tennessee. We started a statewide Safe Sleep campaign in 2012 with new flyers, posters, door hangers, public service announcements, and ads on buses. And we saw a 10% decrease from 2012 to 2013 after implementing that campaign. And we've just finished looking at our data for 2014 and have seen an even larger decrease from 2013 to 2014 after implementing some more of these things. And this shows some of the contributing factors to sleep-related deaths in Tennessee, and it shows that for the top 4 contributing factors are infants found not sleeping in a crib, infants sleeping with other people, not sleeping on their back, and unsafe bedding or toys. And then, as I said, we started the broad statewide educational campaign in 2012. And next, we looked at strategies to target specific populations and groups, such as hospital staff and new mothers through a WIC online educational program. And we also implemented the Floor Talker project and have several of our counties working with the Direct On-Scene Education program. And so I'm going to tell you about some of these initiatives and partners and tips for implementing these if you're interested in implementing them in your state. For the Hospital Safe Sleep Policy Project, we asked all 66 of our birthing hospitals in Tennessee to create a safe sleep policy. We first had a pledge for them to sign stating that they agreed to develop and implement the policy. And then once they signed the pledge form, they each put a contact person on that form. So that way we could continue to follow up with the hospitals to see if they needed help or see what they needed in order to develop and implement that policy. So we worked with those contacts to provide examples and any assistance they needed. And all the policies at a minimum had to include annual education to all perinatal staff on safe sleep recommendations. They had to include requirements for staff to model safe sleep recommendations and education for parents. And then we also required them to report compliance on an annual basis. And it was just a simple annual report that we asked them to fill out because we didn't want them to have to do anything too labor-intensive for the report, since we know how busy people already are at the hospitals. And in return for them developing and implementing the policy, we offered to give them free Sleep Baby Safe and Snug board books for every birth for a year, free Tennessee Department of Health ABCs of Safe Sleep materials. We developed an educational flip chart, and that's designed so that on one side of it, it has a script for the healthcare provider, and the other side, they can show the parent. And so that way the staff at the hospital didn't have to make anything up to educate the parents. It was already done for them. We gave them recognition on our website after they implemented their policy. They got a signed certificate from our health commissioner and a press release template, so if they wanted to send something to their local media, they could easily do that. So that was their incentive for actually developing and implementing the policy. And then I have some results from that project. And this slide shows the average completion time. So most of the policies you can see were developed and implemented within the first 6 months. So we had 87% of the hospitals had already sent us their policy and had started to implement it within the first 6 months of this project. And we had them all within a year. And also, I should say, this slide says 71 hospitals, and I know I mentioned 66 earlier. That was because we had 66 birthing hospitals, but then 5 other hospitals that are not birthing hospitals, they also wanted to participate so that they set up a policy for any babies that were discharged from their hospital. And then as part of the annual report, the hospitals had to report how many staff they trained, how many parents they educated, and how they provided education to them. So you can see this slide shows the different education provided to hospital staff. And 88% of the hospitals provided reading materials to staff. 66% actually did in-person training, and 22% gave them a video. These are not mutually exclusive, so some hospitals may have done one of these things, some may have done all 3. Because as part of the policy, we didn't tell them they had to do in-person education, or we just said that they had to do education for their staff, so they could choose how to actually do that. And then this slide shows the education provided to families before discharge, and 84% provided in-person training to their families before discharge, 93% provided reading materials to the family, and 16% showed them a video. And again, these are also not mutually exclusive, so they could have done all three or could have done just one. But when we looked at the results of the crib, because they also had to do crib audits, which I'll talk about in a minute, but when we looked at the hospitals that used all three of these, they had the greatest decrease in unsafe sleep environments reported on their annual report from the first crib audit to the last crib audit. And this shows how often they did crib audits. We asked that they did at least quarterly crib audits, and you can see that most did. Out of the 43 hospitals that we had annual reports for at the time we analyzed this data, you can see that most did at least quarterly. Some didn't, but some of them had not had their policies implemented very long at this point. And then this slide shows the overall results based on the annual reports that the hospitals turned in. And it shows, and this is based on what they reported from their first crib audit from the very beginning of the project to the last crib audit of the year. And overall, a 45.3% decrease in unsafe sleep environments in the hospital, with toys or objects in the crib having the largest decrease at 51.9%. Infants not asleep on their back decreased by 43.9%, and not sleeping in a crib decreased by 48%. The only thing that we didn't see any significant change in was infants that had a blanket in the crib. And this slide shows some of the successes and challenges of this project. We had a lot of positive feedback from parents and families on the educational materials, and hospitals were creative with their implementation strategies. Some created a model safe sleep crib for their lobby, and others incorporated safe sleep into their breastfeeding training that they were already doing. And some of the challenges are when hospital staff would change and they don't know about the project. So we tried to communicate with them at least once a month to see if they need more books or materials or assistance or anything. And then another challenge was sending out the books in a time frame that would work for each hospital, because some hospitals have too many births to get the books all at once because they don't have storage for them. So we send some quarterly, some semi-annually, some as requested, and some all at once. So we have a lot of hospitals on different schedules to get their books. And just some practical tips for implementation if you're looking at implementing a statewide safe sleep policy. Allow enough time for technical assistance to the hospitals, particularly if you're a big state with a lot of hospitals. There may be a lot of questions and requests. And work with your hospital association. We worked with our Tennessee Hospital Association, and that was really a key to being successful with this project. And providing any templates or samples of materials ahead of time if you have them. It was really helpful to provide a sample crib audit tool and sample policies to our hospitals. And in the very beginning of the project, we didn't provide the sample crib audit tool, and that was something that we got asked a lot about what we wanted that to look like. And then ensuring a staff person at each hospital is assigned to be the safe sleep contact. That has helped a lot to have a specific contact at each hospital. So if we don't hear from them for a while, if we don't get any requests for materials, we can follow up with that person. And then one of the other projects that we are working on is a WIC online educational module. And this online educational module focuses on both safe sleep and breastfeeding. And we obtained feedback from both professionals in WIC, breastfeeding, injury prevention, and child fatality review, and also from parents when we were developing this module. And we pilot tested it in 4 different areas, 2 of our metropolitan areas and 2 rural areas. And we have a pre and post test that measures current behavior and then their intent after they take the module. And then we also ask about what is one thing that they learned while taking this module. And in addition to that, they put in their zip code too, so that we'll be able to pull data on who's taking this and where they're taking it, and if those areas are the areas that we really need to target, if those are the areas with the highest sleep-related deaths. And some of the successes and challenges with this project, we had 181 WIC parents that completed the module in WIC classes, because as we were working to get this actually programmed into a module, we had a PowerPoint that the WIC staff were doing in person with the WIC parents, and we had 181 WIC parents take it that way. And we've had a lot of positive feedback. Some of them have commented that they didn't know this information and they needed to tell their friends about it. Those were just some of the comments that were heard by the WIC staff doing the training. And some of the challenges were creating slides on safe sleep and breastfeeding, just trying to get something that both groups would agree with. And then the time to program the module, because it did take a while to actually get it all programmed, but we're happy to report that we did get it all programmed and it was rolled out statewide at the end of December. So we will have data soon on how many people are actually taking it. But it does have the potential to have a big impact, because we have about 55,000 women that are either pregnant or have an infant on WIC in Tennessee. And just some practical tips for implementation if you're looking at a safe sleep module through WIC. Just engaging all stakeholders in the beginning of the project, getting the breastfeeding people together, the safe sleep people together, parents. Having all those people really helps to get their input first. And just obtaining feedback from all of them. Another project that we've been implementing is the Safe Sleep Floor Talkers project. And these are large stickers designed to place on the floor. They're distributed to clinics, stores, agencies, and businesses that serve parents. And they're really durable. We've had places that have been able to pick them up and put them back down. They've mopped over them. So they do last. We've had about 446 of them placed in 18 months. And this slide shows where they've been placed. 28% are in the health departments or WIC clinics, 19% in doctor's offices or hospitals, and then 18% in stores, and then you can see some various other locations. And then some of the successes and challenges with the Floor Talker project. Some successes are that we were able to engage additional partners in safe sleep that we might not have otherwise had, such as grocery stores and businesses. And it's connected people with other resources, because when people have called to request them, they're often connected to other resources that, since we let them know about other safe sleep resources and materials that we have. Some of the challenges are tracking where they're at and evaluating the project. We track where all of them go and follow up to ensure that they have been placed, which can take some time, but they are fairly expensive, so we want to make sure that they actually get placed. And we also track where they go, because we eventually do want to be able to evaluate this project, so we want to know where they're all placed. And some tips for implementing this: requiring a commitment from the business or agency to place them so that you don't give them out and they just sit on a shelf. And keeping a list of all the Floor Talker recipients. So again, if you want to go back and do a survey to see whether people actually saw them or some type of evaluation, you know where they're all placed. And partnering with community businesses and state agencies such as WIC or Department of Children's Services and grocery stores one of our biggest successes with getting these put out in stores was through WIC, because in one of our health department regions, the WIC staff took them out to the stores when they went to get their annual paperwork re-signed by the grocery stores. So they got several grocery stores to agree to use these. And then be creative with placement. Some of the businesses that have carpet instead of hard floors stuck it on their checkout counter, and some of the clinics placed it on the bathroom door or the door that goes back to the exam room. So we've had some places that have been creative that couldn't put it on the floor. And one of the other projects that we've implemented is the Direct On-Scene Education Program. And a lot of you are probably familiar with this program. It was started by Lieutenant James Carroll in Fort Lauderdale. And we currently have 30 departments participating, covering 18 counties in Tennessee. And that utilizes first responders to educate households with pregnant women or infants about safe sleep. So every time they go to a home that has a pregnant woman or infant, after they take care of the emergency they were there for, they assess whether there was a safe sleep environment, and they educate the parent on safe sleep and help them get a safe sleep environment if they don't have one. And we provide safe sleep kits for them to hand out. And the kits are really just a simple manila envelope with a safe sleep door hanger, a safe sleep flyer, and then a dry erase board with a safe sleep message. And then we also provide pack and plays to all the participating agencies to give out if the family does not have access to a safe sleep environment. And we've been implementing the program for about 1.5 years, and this shows some of our numbers so far. We've had 375 kits have been distributed in 16 cribs, and this shows how many were distributed by either fire departments, EMS, or police departments. We have all three participating. And then some practical tips for implementation of this program. We use SurveyMonkey. So using SurveyMonkey or a similar survey mechanism to have participating agencies report numbers is really helpful. So then they can just click on that survey and report those to you. Because you really need to make sure you're tracking numbers, otherwise you'll have no way to measure whether this makes any impact. Kit distribution, we make all the Safe Sleep kits from our office, so all the requests for them go to the same place. They all come to us. So we found that helpful to do them. That way they don't have to do a lot of work. They don't have to put any kits together themselves. We do that for them. And communication with participating agencies. We communicate from our office at least monthly with the participating agencies and offer encouragement. And anytime someone gives out a lot of kits during a month, we say something encouraging to everybody so they can see what others are doing. So again, just encouraging agencies to utilize opportunities other than emergency calls too. So some of our participating agencies give out the Safe Sleep kits at car seat checks and other community events. And some of the successes and challenges with this program, some successes are that we've had other agencies or venues express an interest in utilizing the Safe Sleep kits to distribute to families, such as the Safe Kids organization. And it has increased media attention on Safe Sleep because we've gotten articles in the newspaper and on the news about the DOSE program in Tennessee. Some challenges are just collecting the monthly numbers. Sometimes it can take some staff time to make sure you get all the monthly numbers. And then staff turnover at participating agencies. Often if you have a new person at one of the participating agencies, you have to explain the program and explain what the previous person was doing. So sometimes that can be a little bit of a challenge. And now, before we move on, we have a poll question. Rebecca, do you have that? So you can see the poll question: will you implement any of the initiatives you heard about today in your state? So I still see a few answers coming in, but it looks like we have about 48 people that said yes, and a lot of people that said possibly. So only a few people that said no, they won't implement anything. So that's encouraging that you must have heard something today that you can take back and implement in your state. And I just want to show again, I mentioned this earlier, that we had a significant decrease in sleep-related deaths, but this shows that we have had a 10% decrease from 2012 to 2013. And as I said, I don't have it on here yet, but we've seen an even larger decrease between 2013 and 2014. And then this slide just shows our overall infant mortality reduction had went down between 2012 and 2013, and we all know that part of that was due to our safe sleep efforts, so we were really excited about that. Thank you, and if you have any questions, you can type them in the chat box, or if you wanted to contact me later, that's my contact information on the slide.
Great. Thank you, Rachel.
Thank you.
Very interesting. So I think it's the question and A period right now, and I have a bunch of questions here on the right. So I think what I'll do is kind of just go through the list, and the first question is for Suzanne. There are many things going on to address safe sleep. How is what you presented different? Connect and collaborate. Suzanne?
Okay, so is what we're doing different? All right, so I think what's different about, can you hear me?
Yes.
Okay, so I think what's different about what we're doing is, first of all, this national level focus and trying to sort of pull together and organize and hear about what's happening nationally and to feel like there's a sort of a national plan and momentum going forward. The other piece is really the idea of really the behavior change and the idea of how can we implement these conversations, because for some people, they hear the information, they take it, and they run with it. But we know there's a large group of people for whom either they don't buy it or they're not really able to implement it without a lot of support. So we're hoping that will bring another dimension to what we've all been doing.
And Suzanne, I'll just, while you're on the line, what is an example of a conversations approach?
Okay, so this is like, you know, you're building the airplane while you're flying, but the idea being, for example, if you think about motivational interviewing approaches, that it's an opportunity to share some information, hear back from somebody, whether they think they can implement that. You know, I think we had a great example from a WIC educator in D.C. who said, well, when the mom says to me, I don't care, I'm going to take the baby in bed with me because that's what I do in my family, to then say, well, let's talk about this some more. Let's talk about the kind of things that, you know, what's in the bed that you think might endanger your baby, you know. Let's talk about the pillows. What else do you think you could do? Is there something that might help you think about the idea of just having the baby right next to you? What would be a problem with that? And trying to engage them back and forth. And then also for families who say, well, I don't know if I can figure out how to do this because of this or that challenge, there'd be an opportunity to brainstorm with them and have them walk out with some kind of plan of action of their own about how to do it, not just what to do.
Great. Thank you, Suzanne. A question for Rachel. Was there any resistance from the hospitals to create policies? And I'll combine it with another question. Can you repeat why you have 71 hospitals in Tennessee involved rather than 66?
Sure. There really wasn't any resistance, and part of that's because we had such good support from our Tennessee Hospital Association. So as I said in the presentation, I would really encourage people, if they're going to implement something like this, to reach out to their hospital association, because that was really key to being successful with this. And we have 66 birthing hospitals, but then there were 5 other hospitals that had heard about the project and said, well, we aren't birthing hospitals, but we do have babies that come in sometimes, and we have to, then we discharge them, so can we participate too? So those 5 other hospitals are actually participating, even though they're not birthing hospitals.
And just along the same line, was there any resistance from breastfeeding advocates for the Safe Sleep breastfeeding module?
So far there really wasn't. It took a while to get the slides to make them so that everyone was happy with them, but we're housed in the same division as our WIC and breastfeeding group, and so we've had a really good working relationship with the breastfeeding group here in Tennessee, and we've worked on previous Safe Sleep projects together, so I think that helped.
Great. Thank you, Rachel. Suzanne, a question came up. How can NAP's activities support state and local efforts?
Well, as I mentioned, I think first of all, as our work groups get moving, there may be some things that we're making happen at a national level that can really support your work. So, for example, the child care piece. Instead of having that be piecemeal state by state, if the National Child Care Association is on board and a number of other people, we may be able to put the kind of supports and pressures in place that it can be a national initiative rather than each state or locality trying to deal with their child care folks. We also hope that we've got a lot of people involved in helping us develop this conversations approach, and so we're hoping that we'll have something to share with folks for them to take and tailor to what they need, or we're hoping, I'm going to be calling Rachel tomorrow about their integrated approach of breastfeeding and safe sleep. That is the other thing at the national level that's really happening. When they first asked us to bring together breastfeeding and safe sleep, I think in their minds it was, could we all sit in the same room and truthfully have a civil conversation? Fortunately, the timing was perfect because NICHD had done some of the work with the breastfeeding community and had really moved that along. But we now have the executive director of the U.S. Breastfeeding Committee as part of our steering committee working together, and they have a group that's working on some safe sleep issues, and we're cross-pollinating that and trying to bring some of those national breastfeeding organizations together with the safe sleep pieces. I think that's going to be an important contribution.
Thanks, Suzanne. And one question, New York State Perinatal Quality Collaborative Safe Sleep Project has been working on data for the last few months. Are you in collaboration with this group?
Is NAPS? No, not specifically.
Oh. Okay.
I mean, we're happy to talk to them, but we're not working with them at this moment.
Rachel, a question for you. How have you chosen the projects you have implemented?
We've really looked at our data and then looked to see where we can get the most impact. And for WIC, we've seen that there's 55,000 women that are either pregnant or have an infant on WIC. So that's a lot of people that we can potentially impact with the WIC and breastfeeding module. And then with the hospital project, by implementing the policies at every hospital, we touch almost every parent that way. So really just looking to see where we can get the most impact.
And Rachel, I have some quick questions here that I think we'll have some quick answers. What is done with a crib audit and who does it?
That's a good question. The crib audit is really simple. We really just ask the hospitals to pick a day and look at all your cribs in your nursery and wherever else you have cribs and put down information about was it a safe sleep environment? If not, what was wrong. Did it have a blanket in the crib? Did they have a toy? Was the baby in bed with the mom? And then we asked them to do those quarterly, and then we look at that data to see what the difference is between the first crib audit they did and the last crib audit.
And Rachel, how much do floor talkers cost?
They're about $18 a piece. The way we print them, they're a pretty thick and durable material since they go on the floor.
And where can you get the floor talker stickers?
We have them printed at our state printing services, but if anyone is interested, I can send you the PDF file of that. We have had a few other states that have used the file and put their own state information on them and had them printed at a printing agency.
Rachel, who funds your program?
It's a mix of funding since, like most states, we don't really have any specific Safe Sleep funding. So we are one of the states funded for the CDC Injury Prevention Grant, and Safe Sleep is one of our priority areas. So we use some funding from that. We have a grant from our Medicaid agency that we have used some funding from, and then we also use some funding from the MCH block grant. So we kind of pull from wherever we can.
Mm-hmm. Let's see. And Rachel, let's see. Here it is. Indiana is doing a statewide dose blitz this summer. The tracking piece is the biggest challenge they've found. We'd like first responders to not just report numbers, but names, addresses, if possible. Ideas for him. I think the question is for Rachel.
So right now we're only tracking the number of kits and cribs, and we're not tracking any names or anyone that they go to. But if anyone, if you'd like more information about how we actually implement DOSE here, you could contact me directly.
And so what's included in the DOSE Safe Sleep kits?
In our DOSE Safe Sleep kit in Tennessee, we have a Safe Sleep flyer, a Safe Sleep door hanger, and then a dry erase board that has emergency numbers at the top, and then at the bottom it has a Safe Sleep message. And the reason behind that was we thought that was, with something that had emergency numbers, we thought that was a perfect connection between the first responders. And also the idea was that the parent would put that on the refrigerator, and anytime they had a babysitter or a different caregiver, they would show them the emergency numbers, and then that caregiver would also see the Safe Sleep message.
And one final question. Are either of you, Suzanne or Rachel, aware of any states that have created a law to ban crib bumpers?
Maryland, I know, because I live in Maryland.
And I think hasn't the city of Chicago? They might have, but I don't know of any others.
Okay. So there are a couple more questions or comments or recommendations within the question and A panel. We don't have time to get to everything. I wanted to take one last minute to thank our speakers. Rachel and Suzanne, thank you so much for taking the time to present your presentations to us today. Very interesting. It sounds like there's a lot of hard work and creative thinking going on, a lot of new direction, and hopefully this plateau is going to start going down. This plateau in SUID death rates is going to start going down again. Their contact information for our speakers are on their slides, and we will post the slides in the next few days on the CSN website. I ask all of our attendees to take a look at the screen and do our SurveyMonkey evaluation of this webinar. And with that, I'm going to thank everyone for coming and end this webinar. Thanks a lot, everybody.